Welcome everybody to the CTSI seminar series. Lucy, you forgot the screen went off again. It's nice to have everybody here. And this will be the, I guess, the fourth installment of the CTSI Distinguished Seminar series. We started off with our own Lily Yang, we had Mary Murad, we had Matthias, and today we have Dr. Pam Sharma. And we can look ahead, especially for those in the immunology series who are interested. Wendell Lim will be here in a couple of weeks. Liz Jaffe, Owen Whitty will be here at the 1st of January. So for those of you in the immunology series, thank you for joining us. So why don't we let Begonia, Dr. Komanandui, she will do the introduction today for Dr. Pam Sharma.
Hello, everybody. It's a very honor to present our speaker, Dr. Pam Sharma, a medical oncologist and an immunologist from MD Anderson Cancer Center. Dr. Sharma has a degree in biology and a master in biotechnology from Boston University, a medical degree and a Ph.D. in immunology from Pennsylvania State University. She also has did her residency at New York Hospital, Cornell Medical Center, clinical and postdoctoral fellowship at Memorial Sloan Kettering Cancer Center. Nowadays, she's in MD Anderson. She has a professor in immunology department. It's a professor in genitourinary medical oncology, co-director of the Parker Institute for Cancer Immunotherapy, the TC Janet Hugh Indove Chair in Cell Biology. She's also inaugural scientific director of the immunotherapy platform that I think she founded, more or less. Faculty member of the University of Texas Graduate School of Biomedical Science. If you don't have enough, she was the first in 2004 who did conduct a preclinical neoadjuvant with immunocheckpoint inhibitors, CTLA-4 of course, and she discovered ICOS ligand pathway as a novel target. Not only this, she also demonstrate human tumor express VISTA as an immunosuppressive pathway, also the first to demonstrate anti-CTLA-4 plus inhibition of EZH2 can improve anti-tumor response in cancer. If you have not realized, she's at top of the translational studies, and especially she likes to call reverse translation. And she also is an active mentoring of new generation of scientists, especially in women and Asian in Pacific Island. So after this short introduction that she has a lot of more things that she has done, let me enjoy her lecture. Pam, your turn. Oh, you are in mute.
Sorry, I just realized that. Thank you. Thank you so much for that wonderful introduction. And I'm thrilled to be presenting here today. As you can see, I will be giving more of a translational research presentation because we're going to go from the clinic to the lab and talking about some of the work that we've done over the years in terms of investigating mechanisms of response and resistance to immune checkpoint therapy. So just as a brief background, I want to remind everybody about this yin and yang of the immune response. It is very tightly regulated. So the same signals that will turn on the T cell response, for example, such as TCR interacting with MHC and antigen as signal 1 and CD28 interacting with B7 as signal 2. These signals will turn on the T cell, but it will also lead to upregulation and expression of inhibitory pathways such as CTLA-4. And this is the way that the T cell response will control itself. And this is a concept that you'll hear over and over. The yin and the yang of the immune response. Inhibitory pathways occur in response to driving the immune response towards an on or activated state. So of course, as you know, Jim Allison proposed a blockade of the inhibitory pathways such as CTLA-4 with an antibody would then allow for prolonged T cell responses and tumor rejection. And so anti-CTLA-4 opened an entire new field called immune checkpoint therapy. This cartoon, as you can see here, depicts some of the pathways that are currently being explored. And of course, CTLA-4, PD-1, and PD-L1 are the major pathways that have now had clinical approvals. To just highlight again the dynamic nature of the immune response, this cartoon depicts a potential time of biopsy of a patient's sample, where you can see there may be T cells, but they're not activated as of yet. And maybe at some point they see antigen and they become activated. And so at the initial time point, you may not have seen any PD-1 expression, but after they become activated, T cells will also upregulate PD-1. So it's not just a marker of exhausted T cells, it's also a marker of activated T cells. And of course, activated T cells will make interferon gamma, and interferon gamma will lead to upregulation of PD-L1. And it's at this time point that now you can see PD-L1 expression in tumors. And this may explain why sometimes it's difficult to use some of these biomarkers for patient selection, because they're so dynamic in their nature. So as of this point in time, we have many FDA approvals. Of course, ipilimumab was first approved. The anti-CTLA-4 antibody by BMS was approved in 2011. And in the last 10 years, you can see how quickly this field has grown with multiple approvals across many tumor types, because we're not targeting tumor cells. We're targeting the immune response, and these immune responses can play a role in many, many different settings. However, there are research questions that still need to be answered. Why do some patients respond and others do not? Can we identify biomarkers that predict response or immune-related toxicities? And I won't have a lot of time to talk about that, but maybe if there are questions, we can discuss that. Are there biomarkers to enable patient selection for treatment monotherapy versus combination therapy? And this is important because combination therapy has higher frequency of toxicities as compared to monotherapy. Can we increase the number of patients who respond? And are there other pathways that can be targeted to improve clinical outcomes? So to do that, we've been thinking about this reverse translation approach, as you heard about, because most of the times when we're working in the laboratory, we're working with mice that are inbred and the disease is homogeneous. And this model system is great because it allows for hypothesis testing, meaning you can knock in a pathway, knock out a pathway, and really understand the impact of that pathway. However, in patients that's polymorphic and the disease is heterogeneous, the data that we get from the clinical trials will be hypothesis generating. And then we have to take that data back to the laboratory to test in appropriate models. And we have to start with patients at this point in time, because if you were to look in clinicaltrials.gov, we have maybe over 2,000, maybe even up to 3,000 clinical trials that are ongoing with immune checkpoint therapy. So really, we have to learn from these clinical trials. So one of the things that we've had to do is rethink clinical trial design to obtain appropriate samples for laboratory studies. And as you know, the phase 1 clinical trial is a safety dose escalation, phase 2 is efficacy, and phase 3 is comparison to standard of care. What we propose are these pre-surgical or window of opportunity or tissue-based trials that we call phase 1A or phase 2A. So that one, we can get an idea of clinical signal in an earlier disease setting, not a metastatic disease setting. We can also have access to the tumor tissues at the time of surgery to really look at biomarkers and gain insights into the mechanisms. So we initiated these studies in 2004, and the first protocol was in 2006. I'm highlighting these dates because these dates are prior to any FDA approvals of any immune checkpoint therapy agents. And I want to highlight that because, again, as we're seeing more and more of these novel pathways and agents being tested, the anti-LAG3, anti-TIM3, anti-GITR, anti-TIGIT antibodies that are out there, I want to also say that although they're not FDA approved agents yet, that we can also start thinking of how to use them in these sort of window of opportunity or pre-surgical trials so that we can understand their mechanism of action on the tumor microenvironment. So this is the first clinical trial that we did in patients with localized bladder cancer. Couple of points to highlight. One, it's a small clinical trial. We only did this in 12 patients. We're not looking for p-values in terms of overall response rate or overall survival here. We're really doing the clinical trial to have access to the samples so that we can take them back to the lab for in-depth immune monitoring studies. And so here, these 12 patients with localized bladder cancer were scheduled for surgery. We asked them to participate in the clinical trial to get 2 doses of antibodies prior to surgery. And at that time, then we can have access to the samples. The trial was very important because, one, it was the first trial with an immune checkpoint agent in the setting of bladder cancer. So again, it gave us a clinical signal for efficacy since 3 patients developed pathologic complete responses, indicating that bladder cancer can also be a tumor type that we can treat with immune checkpoint therapy. And of course, we use these data to then develop more studies in the metastatic disease setting, which eventually led to FDA approvals. It also gave us the first clinical trial with immune checkpoint therapy in the neoadjuvant setting prior to surgery. And this gave us the clinical signal for safety, meaning now that we had an understanding that immune checkpoint therapy was safe to give prior to surgery. And as you know, there are many, many more neoadjuvant studies that are now ongoing. Importantly, though, it did give us access to all of the tumor tissues that we can then look to understand what was the immune response that was ongoing within the tumor microenvironment as a result of treatment. And what we did see was an increase in infiltrating cells, as seen here. These were CD3 positive, CD4 positive, CD8 positive, granzyme B positive, as well as CD20 for B cell positive. So this indicated an increase in immune cell infiltration. And it's to be expected, given that the mechanism of action of the antibody was to enhance immune responses. What we also saw when we compared pre and post-treatment samples for gene expression analysis, we saw that the ICOS pathway was the top pathway that was expressed. And all of these pathways, of course, are related to immune response. So that's not surprising since we changed the frequency of the immune cells within the post-treatment samples. However, ICOS had not been studied in anti-tumor responses before, and so we wanted to study that more closely. Just as a reminder, ICOS is inducible co-stimulator. It belongs to the CD28 and CTLA4 family, and it has a very diverse role that's been reported, including that it's associated with follicular helper T cells. And in this setting, it expresses the transcription factor BCL6. It also has a role in, it has been seen in regulatory T cells, but a role in anti-tumor responses had not been established. So we wanted to understand whether or not ICOS was in regulatory T cells or effector T cells or follicular helper T cells. And so we went back to the patient samples where we could then look at ICOS from protein expression by flow cytometry as shown here. And this confirmed our gene expression studies because we saw that again, after anti-CTLA4 treatment, ICOS was significantly increased as compared to untreated or non-malignant tissues on the CD4 T cells as shown here. We wanted to investigate the function of these T cells. And again, because we had patient samples, we could see that these samples express certain antigens, such as the NY-ESO-1 antigen as shown here. And we could sort the T cells from the tumors and ask whether or not they could identify these antigen in vitro assays, such as ELISpot assays looking at interferon gamma production, or cytospot assays looking at TNF alpha and MIP1 beta production. And here you can see that these T cells were quite capable of recognizing the antigen, and they were behaving as effector T cells that could produce Th1 cytokines. We also did a retrospective analysis in collaboration with Jed Walchuk's group because they were conducting the phase 3 clinical trial at that time with anti-CTLA4 in patients with metastatic melanoma. And here you can see we had about 80 patients where we were able to then show that patients who had increased levels of ICOS positive T cells had much better survival as compared to patients who did not. In another clinical trial that we conducted, and here we conducted this again, a combination study with anti-CTLA4 tremelimumab and anti-PD-L1 durvalumab in patients with localized bladder cancer. And this again, another neoadjuvant pre-surgical trial, another small trial. Here we had 28 patients who were treated, and they received 2 doses of the combination therapy prior to surgery. I should point out that in this group of patients, these patients were not eligible for any neoadjuvant chemotherapy because they were cisplatin ineligible due to medical comorbidities. And since these patients have a high rate of disease recurrence, since they do not receive a neoadjuvant therapy and they have no standard of care neoadjuvant therapy, we thought that maybe we could have neoadjuvant therapy developed for these patients with immunotherapy. And you can see the pathologic complete response rate here was 37.5% in the patients who went to surgery. And even in patients who had large 3D masses, CT4A disease, you saw that we had a pathologic complete response of 42%. So clearly indicating clinical efficacy and possibly moving this neoadjuvant treatment of combination forward for approval in these patients who do not currently have a standard of care neoadjuvant treatment. Again, though, importantly, from a biomarker standpoint, we were able to have access to the samples at the time of surgery, and we were able to identify tertiary lymphoid structures as shown here as higher in the responders as compared to the non-responders. And tertiary lymphoid structures are made up of dendritic cells, B cells, and T cells. And what we found was that the T cells that were increasing in the responders, again, as you can see, are these ICOS positive CD4 T cells. And so again, these may be playing a role since the ICOS ligand pathway is also very important for T and B cell collaboration. So the first hypothesis that we took away from the clinical studies was, of course, that the ICOS ligand pathway is necessary for effective anti-tumor immune responses in the setting of anti-CTLA-4 therapy. And we wanted to test that in a murine model. So we went back to the laboratory and we had the ICOS knockout mice and the ICOS ligand knockout mice. And you can see when these mice had tumors and were treated with anti-CTLA-4, they had impaired anti-tumor responses and tumor rejection as compared to wild type mice, clearly indicating the importance of the ICOS ligand pathway. We also wanted to understand why is the pathway important. And so we proposed a second hypothesis was that ICOS can induce signaling via PI3 kinase to promote Tbet expression. And Tbet is a transcription factor to drive Th1 responses. And so we proposed this because ICOS is related to CTLA-4 and CD28, and all of these proteins have PI3 kinase binding domains within their cytoplasmic domain here. And so again, we went back to the wild type and the ICOS knockout mice, and you can see here we had CD4 T cells from spleen, tumor draining lymph nodes, and the tumor infiltrating lymphocytes themselves. And you can see when the mice are untreated, the cells from the spleen, as you can see here, from either the wild type or the ICOS knockout mice, they do not express Tbet. However, after treatment with anti-CTLA-4, now you can see that Tbet expression increases in the CD4 T cells from wild type mice, but not from the ICOS knockout mice. And I should point out that all of these cells are CD28 positive. And so it's important because many people think that CD28 is a signaling pathway for Tbet expression. And that may be early on during a T cell response as CD28 is playing that role. However, we think that ICOS is also playing that role later on in the immune response. However, that data did not help us to understand whether it was the PI3 kinase pathway that was responsible for the Tbet expression. And so we used the ICOS-YF mice. And these mice express ICOS, but they have a single amino acid change from Y to F in the cytoplasmic domain. And so they cannot signal through PI3 kinase. They do not allow for binding of the PI3 kinase. So what we found in these cells, if we looked at wild type and ICOS-YF mice, the CD4 T cells can now be sorted as ICOS positive or ICOS high and ICOS negative or ICOS low as shown here. And again, it's the ICOS positive or ICOS high cells from wild type mice that had the Tbet expression, but it didn't matter if they were ICOS positive or ICOS negative from the ICOS-YF mice, they still could not express Tbet. And this is due to impairment of PI3 kinase signaling. So clearly PI3 kinase signaling is playing an important role in T cell responses. The third hypothesis we had was that the ICOS ligand pathway can be targeted and developed as a combination therapy strategy. And to do that, we conducted these experiments in collaboration with Jim Allison's group, whereby we could then target ICOS with anti-CTLA-4 antibody. And in wild type mice, you can see here in the blue dotted line that these mice had much better anti-tumor responses and tumor rejection with long-term survival as compared to any of the monotherapy studies. But when we did the same experiments that we did in wild type mice in the ICOS knockout mice, we lost the ability to have that response, clearly indicating the importance of the ICOS pathway. And so there are many groups now trying to develop agonistic anti-ICOS antibodies. And I should say it's very difficult to develop an agonist antibody as compared to an antagonist antibody. So we have to be careful in the antibody development strategy to make sure that we have the right way of targeting ICOS. I do want to switch gears a little bit because now we've talked about melanoma and bladder cancer, and you're well aware that there are FDA approvals of immune checkpoint therapy agents for melanoma, bladder, and lung cancer because these are considered so-called hot tumors. And these tumors have lots of mutations as shown here, and it's thought because they have lots of mutations, they have lots of antigens for T cell responses. However, prostate cancer and other tumor types that have fewer mutations are considered cold tumors because it's thought that they do not have antigens that can be recognized by T cells. And so from a clinical standpoint, I can understand that because again, we've had over 3 failed phase 3 clinical trials with immune checkpoint therapy in prostate cancer. And so from a clinical standpoint, maybe prostate cancer will not respond to immune checkpoint therapy. But as an immunologist, we know that T cells only really need a single antigen. in order to have a T cell response. It doesn't need thousands of antigens to generate a T cell response. So prostate cancer is a tumor, and all tumors should have mutations. And so the T cells should be able to recognize those mutations. And so we wanted to ask that question in a clinical trial. And so here, this is a clinical trial in patients with metastatic castration-resistant prostate cancer. This was another small trial, 30 patients, where we could resect the prostate cancer tumors. We can perform exome and RNA sequencing, and we can identify the tumor mutations. And then we can treat the patients with anti-CTLA-4, ipilimumab is shown here, and collect T cells from these patients and ask whether or not the T cells can recognize these mutations that we identified. And so this paper was published last year, so I won't go into all of the details. But what you can see here in patient number 7 was that this patient had 2 mutations, one in rogue guanine nucleotide exchange factor 37 and one in dihydropyrimidase. These were single amino acid mutations. And you can see that after treatment with anti-CTLA-4, the T cells from this patient were quite capable of recognizing the mutated antigen, but not the wild type antigen. So again, it's clear that T cells in prostate cancer patients can function to recognize the antigens. So if the mutations can be recognized, is the problem that the T cells are not infiltrating into the prostate tumors. And so we had another clinical trial, again, another small trial in the pre-surgical or neoadjuvant space with 20 patients with localized prostate cancer. And these 20 patients were asked to receive 2 doses of anti-CTLA-4 prior to surgery. And we had access to all of the samples as shown here. And now what you can see, the prostate cancer in a pre-treatment setting is clearly a cold tumor. It has very few infiltrating immune cells as shown here. But after treatment with anti-CTLA-4, now you can see lots of infiltrating immune cells. So we did convert this cold prostate tumor into a hot tumor. However, we should have been prepared as immunologists for exactly what I told you at the beginning. When you drive the immune response in one direction, it will have compensatory inhibitory pathways that are expressed to control that immune response. And what we found in the gene expression studies here was that we had an increase in VISTA and PD-L1 as inhibitory pathways. And so we confirmed the gene expression studies by IHC studies as shown here. And you can see again, PD-1, PD-L1, and VISTA are not expressed in the pre-treatment samples. However, after treatment with anti-CTLA-4, when we have all of the infiltrating immune cells and we have an ongoing immune response, now you can see that there's increase in PD-1 on the immune cells, PD-L1 on immune cells and on tumor cells, and VISTA on the immune cells. And I should point out that VISTA is a novel inhibitory pathway that was identified by Randy Noel's group. Our data was the first to show that it exists in human tumors as a compensatory inhibitory pathway. So PD-L1 expression is shown here, and the red dots is the post-treatment samples, and black triangles are the pre-treatment samples. And you can see that post-treatment, it's really increasing on the CD8 T cells, CD68 macrophages, and the tumor cells. And similarly shown here is VISTA, and you can see that VISTA is increasing with a higher frequency actually on the CD68 positive cells. And I do want to point out that VISTA and PD-L1 are distinct subsets. It's not the same macrophages that are expressing these. Predominantly, you can see that there are CD68 positive VISTA positive cells. These are single staining VISTA positive, as well as CD68 positive PD-L1 positive cells. Again, single staining PD-L1 positive. And very few cells that express both PD-L1 and VISTA in this immunofluorescence analysis is shown here. So both of these pathways may need to be targeted in order to have responses in prostate cancer patients. When we also asked why is prostate cancer patients not seeing a response with immune checkpoint therapy, whereas melanoma is, we compared the post-treatment melanoma samples to post-treatment prostate tumor samples. And what we found was that in melanoma, the myeloid cells really had an M1 gene signature, meaning that these cells participated in tumor rejection. Whereas in prostate cancer, we found an M2 gene signature, and meaning that these cells were now helping with immune cell suppression. And so why M1 cells are differentiated in melanoma, whereas M2 cells are differentiated in the prostate tumor microenvironment is still an ongoing area of investigation. But I will point out that recently it's been found that T cells express things such as androgen receptor. So imagine that the T cells now have hormone receptors such as androgen receptor, and androgen is very much part of the prostate tumor microenvironment as well. You can understand that there may be differences in how these cells are receiving signals and how they may differentiate. We did show that VISTA and PD-L1 are potent inhibitors of human T cell responses, as shown in this in vitro analysis. We took the T cells from the patients, incubated them in vitro with anti-CD3, and you can see that they're quite capable of producing TNF-alpha and interferon gamma. However, if the plate is coated with a PD-L1 immunoglobulin or a VISTA immunoglobulin or the two together, you can now see that we had decrease in the TNF-alpha and interferon gamma production, indicating suppression and inhibition of the T cell response. Based on these data, we worked with Bristol Myers Squibb to then propose a new clinical trial with anti-CTLA-4 plus anti-PD-1 in patients with metastatic castration-resistant prostate cancer. So this was the Checkmate 650 clinical trial, and we published this trial last year as well. I do want to point out that we were able to show responses in some of these patients. And here you can see one of our patients who had a PSA up to 500, that after treatment, the PSA became undetectable. We saw a regression of soft tissue metastases, and we also saw some regression of bone metastases, which was very reassuring. However, what we noted was that when we did another clinical trial looking at a combination again with anti-CTLA-4 and anti-PD-L1, we wanted to really treat bone metastases because metastatic castration-resistant prostate cancer goes predominantly to bones. And what we found was that the bone metastases were not responding. And in our Checkmate 650 study, the majority of the responses were really due to soft tissue metastases. And so I won't go into all of the details here because this paper in Journal of Immunotherapy of Cancer was just published this year. But I do want to highlight that we were not seeing responses in the bone metastases. And so we wanted to ask this question: why do clinical responses occur less frequently in patients with bone metastases? And so because we had access to the tumor tissues, again, showing here the prostate cancer soft tissue metastases that we were able to collect from the clinical trials compared to the prostate cancer bone metastases that we're able to collect from patients. When we compared pre and post-treatment samples, you can see that the post-treatment samples from the soft tissue metastases clearly had an increase in the Th1 response, as shown here. Whereas in the bone metastases, we never saw an increase in the Th1 response. We actually saw an increase in Th17 within the bone metastases. And so this led us then to investigate this further. And to do that, we created a mouse model whereby we could take the castration-resistant prostate cancer cells and inject them into the bones of mice to mimic the bone metastases, or inject them into the subcutaneous area to mimic the soft tissue lesions. And then we treated the mice with either IgG as a control or anti-CTLA-4 and anti-PD-1 as a combination treatment, similar to what we did in the clinical trial. And what you can see again in the bone lesions here, we never saw an increase in the Th1 response. We only saw an increase in Th17. However, in the subcutaneous lesions, this was similar to the patient with soft tissue metastases. We did see an increase in the Th1 response, and we did not see an increase in Th17. And because the cells were being skewed towards Th1 development, you actually saw that there was a decrease in Th17 development in the subcutaneous lesions. And so I won't go into all of the details about mechanisms that we explored as to why this may be happening. It was published in 2019. But I do want to highlight that what we identified were there were two cytokines, IL-6 and TGF-beta. And as you may know, IL-6 and TGF-beta are two important cytokines that when they signal together, they will lead to Th17 development. These two cytokines are very important for Th17 development. And what we found in the bone microenvironment was that without tumors, IL-6 is still very high in the bones. So even in the presence of tumors or not in tumors, it was shown as the BM without tumors and BMT with tumors, you can see that IL-6 levels were high as compared to the serum. However, TGF-beta is only high when there's a tumor present within the bones. And that's because this is due to osteoclast activity, as we showed in the paper. So then we proposed that we would have to block TGF-beta in combination with immune checkpoint therapy in order to get responses in bone metastases. And so we did this study in the murine model, and you can see in the green boxes, we did see tumor regression as a response to combination therapy. Importantly, what we found in this model was that as a result of combination with immune checkpoint therapy plus anti-TGF-beta, we had an expansion of these Th1 CD4 T cells, as well as for the first time, an expansion of CD8 T cell clones. And these data then led to, of course, improved survival in the murine model with the tumor in the bones as shown here. And so we've now proposed a new clinical trial, and we're trying to now use a combination of anti-CTLA-4 and TGF-beta inhibitor for patients with bone metastases. What we learned from the studies in the bone was that there are unique niches or microenvironments that may allow for different immune cell subsets to develop. And so we wanted to study this a little bit more. And so we looked at different tumor types as shown here. This was a glioblastoma, non-small cell lung cancer, renal cell carcinoma, colorectal cancer, and prostate cancer. So we compared all of these different tumors to try and understand whether or not there was a unique cell subset that existed within GBM, since GBM is another tumor type that does not respond well to immune checkpoint therapy. And here you can see that we identified by CyTOF this L8 subset, which is a CD73 high, CD68 positive cell subset. And so this subset was only found in GBM, not in the other tumor types that we studied. And more importantly, when we looked at untreated GBM compared to anti-PD-1 treated GBM, we found that this cell subset persisted and was likely the reason why you were having immune responses that were inhibitory. The single cell RNA sequencing analysis that we performed showed here identified a CD73 subset as a macrophage signature, an immunosuppressive signature, and a hypoxia signature is shown here. Based on these data, we then proposed that we would need to inhibit CD73. We didn't have an inhibitor of CD73 at that time, so we used actually wild type and CD73 knockout mice, as shown here. And you can see that once we used anti-PD-1 and anti-CTLA-4, which is the red line in the CD73 knockout mice as compared to wild type mice, for the first time now we had an improved survival of these mice that were bearing GBM tumors. And so now we propose that as another combination strategy that's under review. I want to highlight another pathway that plays a very important role in resistance. Again, just to highlight again that the CD28 and T cell receptor signaling is very important for turning T cells on. It's also the same pathway that then leads to increased expression of EZH2, which is in the epigenetic pathways. EZH2 is very important now for stabilization of the FOXP3 transcription factor being stabilized. And so this FOXP3 transcription factor, as you know, will then lead to regulatory T cell responses and function. So what we saw in patients who were receiving anti-CTLA-4 was that there was an increase in EZH2 expression in CD4 T cells. And what we wanted to know was whether or not we could inhibit EZH2 to try to restore effector T cell responses. And so we used the FOXP3 GFP mice because we could sort the GFP positive cells as FOXP3 positive Tregs and incubate these with or without an EZH2 inhibitor to understand whether we can functionally and phenotypically change these cells. So phenotypically, what we saw was that with an EZH2 inhibitor, we can then decrease FOXP3 expression. We can increase CXCL10, granzyme B, and interferon gamma expression. And functionally, what we saw was that without the EZH2 inhibitor, these cells were quite capable of suppressing effector T cell responses in the CFSE dilution analysis shown here. But once we had the EZH2 inhibitor on board, they no longer functioned as regulatory T cells, and the effector T cells were now quite capable of proliferating. So based on this concept, we then proposed combination therapy with immune checkpoint therapy, anti-CTLA-4 shown here, and an EZH2 inhibitor. And what we saw was that we had tumor regression and decreased tumor volume, as well as improved survival of the mice. And so these data led us to a new clinical trial, as shown here. This protocol was actually IRB approved and now accruing patients. And what you can see is that we're using anti-CTLA-4 and the EZH1/2 inhibitor. This is now enrolling patients with metastatic prostate cancer, bladder cancer, and renal cell carcinoma. We've treated 7 patients to date, and the trial is still ongoing. So hopefully we'll have some data to share at a later time about how these patients are responding to therapy. But we are collecting samples along the way as well, of course, to look for additional compensatory inhibitory pathways that may be occurring. I finally want to end on this topic of biomarkers for selection of patients for immune checkpoint therapy, because I think the field has moved forward in terms of thinking of which biomarkers should we use. And of course, we've seen FDA approvals for things such as tumor mutational burden and MSI status, and even PD-L1. And what I want to point out is that we're either thinking about the tumor cell status, meaning the tumor mutation load, or we're thinking about the immune microenvironment, we're looking at PD-L1. But we may need to think about both. We may need to think about a combinatorial biomarker strategy whereby the biomarkers can tell us about both the tumor cell status and the immune microenvironment. So Sangeeta Goswami, who was in the lab at the time, was working on this study, and she noted that in bladder cancer patients, this is patients, metastatic bladder cancer patients who received anti-PD-1 therapy. On the tumor cell study, she saw that the ARID1A mutations were much, much higher in responders as compared to non-responders. And so based on this smaller study, this was a total of 25 patients that we looked at. We then wanted to go back to larger studies and evaluate this in a retrospective analysis. And what she found was that in the Checkmate 275 clinical trial, which was a clinical trial conducted by BMS with anti-PD-1 in patients with metastatic bladder cancer, and the IMvigor 210, which is a clinical trial conducted by Genentech with their anti-PD-L1 antibody in patients with metastatic bladder cancer, she found that patients, again, who had this ARID1A mutation would have much better survival in both Checkmate 275 and IMvigor 210 as compared to the wild type. So when we looked at what happened in the setting of the ARID1A mutation, we found that these patients were the ones who had higher tumor mutational burden. And again, this is looking at the Checkmate 275 trial, the IMvigor 210 trial, and even the TCGA studies. She also found that ARID1A mutated patients also had lower TGF-beta1 expression within their tumor microenvironment, looking again across IMvigor 210 and TCGA as shown here. And so when we did studies in the laboratory, we asked whether or not we could knock down ARID1A with an shRNA and compare it to scramble to see how these tumor cells responded to knockdown of ARID1A. And you can see that with knockdown of ARID1A, we now had an increase in interferon gamma response and JAK-STAT signaling, and a decrease in angiogenesis and DNA repair pathway genes as shown here. Importantly, what she also saw was that this ARID1A knockdown, when you treat it with anti-PD-1 as compared to the wild type, you can see that you had much better responses with anti-PD-1 therapy using the ARID1A knockdown tumor cells. In same time, in parallel, as she was doing the tumor cell study, she was also looking at the immune microenvironment studies, first in the 25 patients that she initially had. And what she found in those 25 patients was that baseline CXCL13 expression was much higher in responders as compared to non-responders. And so from that small cohort, she went back to the larger studies again, Checkmate 275 and IMvigor 210 is shown here. And what she saw was that CXCL13, again, was much higher in responders as compared to non-responders. So if you stratified patients by CXCL13 high, medium, and low, it was the patients who had high expression in both Checkmate 275 and IMvigor 210 that had better survival in a retrospective analysis. And so we went back to CXCL13 knockout mice. And what you can see when you compare the CXCL13 knockout mice to wild type mice was that the wild type mice were quite capable of responding to anti-PD-1 treatment. However, CXCL13 knockout tumor-bearing mice no longer responded to anti-PD-1 therapy, clearly indicating an important role for CXCL13 in the immune response. And so when we looked at the CXCL13 knockout mice compared to wild type mice, we found that they had higher levels of CD8 T cells in the wild type mice and decreased frequency of these cells in the CXCL13 knockout mice. and higher frequency of myeloid cells in the CXCL13 knockout mice as compared to the wild type mice. And so we went back again retrospectively now to combine the two biomarkers, ARID1A mutation plus CXCL13 expression in both the Checkmate 275 and IMvigor 210 clinical trial. And if you look here now, what you found is that if you had both an ARID1A mutation and high CXCL13 expression, your survival was 19.1 months in the Checkmate 275 study and 17.8 months in the IMvigor 210 study compared to those patients who had wild type or low CXCL13, which were close to 5 to 7 months. A very significant difference in outcomes depending on the ARID1A mutation and the CXCL13 expression. And so based on that data, we then proposed a new clinical trial whereby we now have two clinical trials, I should say, because we wanted two different cohorts. One is protocol 2021-0104, and this trial is accruing patients with metastatic or surgically unresectable bladder cancer. They must have an ARID1A mutation in order to enroll into the study. The second protocol is for any patients, so any tumor types that have an ARID1A mutation can now enroll to receive anti-PD-1 therapy. And we're going to stratify the response based on CXCL13 expression. So it'll be either CXCL13 expression high or low. And we're using the CXCL13 gene expression analysis to then develop an IHC assay for CXCL13 that can be CLIA certified and then used in future studies to prospectively select patients for CXCL13 expression. But hopefully these type of biomarker studies that combine both the tumor mutation status as well as the immune microenvironment will help us to move forward with developing strategies to have patients who will truly respond to immune checkpoint therapy, and we'll have a better selection going forward for other studies. So I just want to point out that there are many, many immunotherapy targets, of course, that are being preclinically or clinically developed. This cartoon is actually outdated given the number of molecules that are being looked at. And we at MD Anderson had to think about how to move quickly between the cancer immunotherapy clinical trials and the laboratory interrogation. And so we have developed an umbrella lab protocol that allows us to collect samples from all patients, regardless of which clinical trial they're being treated on, whether it's a BMS study or a Genitech study or a Merck study, it doesn't matter. We can still collect samples under this PA 130291. So we have about over 113 clinical trials where we're collecting samples across 18 departments. About 4,000 plus patients enrolled to date. And these samples are allowing us to then, because we're collecting them longitudinally, we're able to then look at how the immune response is changing dynamically within the patients and within the tumor microenvironments for comparisons. So hopefully these studies will help us as we move forward. And I encourage more of these types of studies in small numbers of patients, of course, before we move on to larger 800 patient clinical trials. So just to conclude, immune checkpoint therapy has joined the ranks of surgery, radiation, and chemotherapy as a pillar of cancer treatment. However, combination strategies need to be what we move forward in the future. But since multiple immune checkpoints exist and are dynamic in their expression, we have to study both the pre and on-treatment human tumor samples to guide the therapeutic decisions and to help us decide about rational combinations. Also, we need to consider the organ-specific microenvironment, bone, brain, other liver, for example. All of these are unique microenvironments that need to be considered in order to understand the immunologic subsets and the subsequent immune responses against cancer cells that can occur in these organs. And I hope I've convinced you that pre-surgical and tissue-based clinical trials provide a feasible platform to study biologic effects in patients, which provide insights into mechanisms that can be targeted for rational combination therapies. So I have many, many people to thank. The work that was shown today, Sangeeta Goswami's name was on the slides for her studies, and she's now in her own lab. So I'm very happy for her. She's moving forward. JJ Gao also, his studies shown in the slides, and he's also now in his own lab. There were also studies shown by Sumit Subudi and other members of the lab as I went through. I do want to thank the geomedical oncology, urology, and pathology groups. As you can see, this is a team effort. Many, many people are involved in these translational studies. The Immunology and Immunotherapy platform for all of their input and help. And of course, always, always, always the patients for participating in our clinical trials. So thank you, and I'm happy to take questions.
Thank you, Pam. So amazing. So many different things that you guys are doing. And I love how you're going back between the patient samples and the mice. And, I think these are the kinds of things, I think, especially in this neoadjuvant setting. I mean, we certainly are very interested in that in the brain tumor group as well. Before I think, but we start off the questions, I think the first one, which I think is important. I mean, me in the brain tumor space, and I know you've been here too, but I think the importance of checkpoints in macrophages versus tumor cells. It'd be interesting to hear your take on this, mostly because you've worked, I worked mostly in the GBM space, and we clearly think about macrophages a lot and immunosuppression, but you go in, all these different other tumor types, and there are varying degrees of macrophage infiltration and the response. It'd be interesting to hear your perspective on what this means in the different tumor types and how important they are.
Yeah, I think one of the things we have to keep in mind is the tumor immune cell interactions. And that's why different tumor microenvironments may have very different things happening. Why in melanoma, we're seeing more of the M1 cells develop, right, with immune checkpoint therapy, whereas in prostate cancer, we're seeing M2s develop. So, and I think similarly in GBM, there's definitely crosstalk between the tumor cells, the immune cells, the stromal elements, right? And so they are going to influence how the myeloid cells develop. So it's not just what are the myeloid cells or the tumor cells expressing, right? What checkpoints? It's when are they expressing it, right? So it's longitudinal. And the setting in GBM is really difficult because we're not getting longitudinal analysis, as you know, right? I mean, you guys have been trying to get maybe some samples at the time of surgical resection, but it's not in a longitudinal manner because you can't keep going into the brain multiple times to get those samples to see how the environment is changing. I know that Breakthrough Cancer now is working with many of our institutions to try and put together one of these longitudinal biopsy, six time points of biopsies in GBM patients. So we'll see if that trial is, move forward so that we can actually try to understand. But I do think it's important to understand why the checkpoints are being expressed at a certain time point and what's the signaling mechanisms that lead to certain checkpoints being expressed. And again, we're now learning that, T cells, for example, have serotonin receptors, have androgen receptors, have all of these things that may be playing a role within the brain microenvironment very differently than it could be in lung or liver, for example. And we're not aware of how those are being regulated. So I think it's going to take a lot of work for us to figure it out, but we have the technology. I think for the first time, we have the technology where we can actually start to interrogate the human samples in so much details to generate really meaningful hypotheses that we can test mechanistically in models. And unfortunately, they're not great models because a lot of our models in cancer have been not immunocompetent models. So hopefully we'll get more immunocompetent models that we can look at myeloid cell development and really understand what checkpoints are being expressed at what stage of development.
And along that line, do you think there's a difference between tissue resident macrophages versus inflammatory ones that come out of the blood and the bone marrow? Is that something you guys think about?
Yes, absolutely. And yes, they do have, I think, different roles that they play, and they do respond in a different way to signals that they're seeing, right? Mostly because also their epigenetic programming that's there that allows certain pathways to be expressed in the tissue resident ones that may not be expressed in the inflammatory ones or the trafficking ones. And so understanding those epigenetic programs that are in place also become important because, like I showed with the EZH2 and T cells, there are also epigenetic pathways that can be targeted in macrophages, but you need to know which tumor type are more having the resident ones versus the inflammatory or trafficking ones.
Yeah, good. Vega, why don't you ask your question?
Yes, I have a question, and after there are a panelist question. Highly impressive didactic talk. You talk about organ-specific microenvironmental. So does target directly to tissue resident immunocells? Have you studied a little each? You have a lot of models. Each tissue residence immunocells, its affect the output of the immunotherapy, or no?
So in the human setting, no, we haven't done a lot of that in the human setting. I think there's a lot more of that in the murine models, but we haven't been able to define them. You know, the markers that define some of these things sometimes very well in murine models are not great in the human setting, especially when you start thinking about myeloid cells, right? Even now, like we love to throw around the term MDSCs or myeloid-derived suppressor cells, for example. And I think that's very well defined in the murine models. I'm not so sure that it's well defined in the human models at all. And so we use some markers that we think may be phenotypically defining them, but functionally, if you were to test it, don't. I think this happens also with the resident cells that we think about as resident cells and may not be, because they upregulate different markers at different time period, and we may not be seeing when those markers are upregulated. So I worry a little bit that the terms are much better defined in murine models and the markers are much better defined in murine models than they are in human systems. So we haven't been able to really correlate that yet with clinical outcomes.
Okay, thank you. There are a question from Eris Ribatsan. He said, I'm not sure you address it. Isn't important to compare M2 to M1 so that I could be addressed for any human tumor?
So M2s, you know, again, the markers for M2s and M1s have overlap as well. So they're not great markers, but on a gene signature panel, we are trying to use, you know, some of those genes that tend to have more with M2 association versus M1. You know, there's the INOS, the arginase, all of these markers that we're trying to use to differentiate. So I think you'll see some overlap of some genes, but we do find that we can differentiate a few genes between the two that can help. And then we try to test those out also by IHC just to confirm gene expression studies. I hope that answers the questions. I wasn't really sure.
Eri, it has answered your question?
If not, please feel free to ask me again.
Yes, please.
I think I was right. I think he's questioning whether it's important to convert M2 to M1, and if that matters.
So I think when we see responses in the clinic, we're definitely seeing more M1s. Now, does that mean that M2s were converted to M1 or they're trafficked in? I don't, you know, you don't know in that setting. I don't know how to say that maybe the tumor microenvironment had a lot of M2s and then they were converted to M1. That could be because you're seeing more interferon gamma and maybe there's some cytokines that are causing that. Or whether you've now trafficked in so many more M1s that the M2s look lower in frequency, right? It's a numbers game and a timing.
So are you thinking about different inhibitors for that target myeloid cells? I'm wondering what your strategy is there, because certainly in prostate and in pancreatic and all these, I mean, maybe not melanoma, but in many of the other, as we talked about at the Parker Institute, for those of us on the poor side of town, speaking of the T cells, the T cell poor side,
yeah,
you know, we can increase T cells to a certain extent, at least with the existing therapies, but we're so overwhelmed by these macrophages, myeloid cells, that we think that it's kind of overrunning. And I'm curious what your thoughts are on that.
Yeah, we're definitely moving forward with like an anti-VISTA study. We have one now that's moving into phase 1 clinical trials, looking at safety dose escalation for a new anti-VISTA antibody. We also have studies that we're developing, you know, targeting the CD73, CD39 pathway, you know, looking at that as a way to move forward in terms of targeting myeloid cells. And then, of course, there are epigenetic inhibitors that we're testing for their differential effects on myeloid cells as opposed to T cells. So I think these are ways in which we can think about it. I think other people are trying to think also of ways that, and these may be really successful ways to think about it as well, you know, where you're using oncolytic virus or other sort of ways to drive innate immune responses so that you're getting more of an innate immune response that's consistent with an antiviral response. And maybe that can move it towards then more M1 because you're, you know, supposedly driving more of this inflammatory response and taking advantage of that in the setting of cancer to then add that in with an immune checkpoint agent to bring in the T cell part of it.
Oh, Eric has answered again. My query is, do we have look for individual markers and treat them or a combination therapy for the different markers from M2 to M1?
Do we? So I don't know of anyone that's doing combination of markers to treat myeloid cells. I think, we're sort of hypothesizing that if you can figure out a single pathway, whether it's a epigenetic pathway or what it's VISTA or, some other pathway, that you start to help either get rid of the M2s or start to convert them from M2s to M1, then that would be sufficient. I don't know if we'll need combinatorial targeting of the M2. It may be, but I'm not aware of any data like that yet.
Or do I?
Okay.
Well, I think, do we have any more, Bego?
No, by the
Okay.
moment. You
I
let
think-
all the people speechless with your question. Oh, one more.
Either that or it's time for everybody to take a break.
Hmm.
One more from Hui Ye.
Mhm.
Sorry if I don't pronounce correctly. What's your take of research direction on epigenetic regulating drugs? The current global epigenetic modification agents will upregulate different gene expression in both immunocells and tumor cells. Shall we develop pathway-specific cell-specific epigenetic modifiers?
Yeah, it would be great if we can. I agree with you. I think epigenetic agents, people have used HDAC inhibitors and these kinds of things in the past, and they weren't very specific in what they were doing. So I do think we need more specific agents. For example, even with the EZH2 inhibitors, we have to be thoughtful that we are going to affect tumor cell pathways. It's actually one of the reasons I'm very excited about the prostate cancer portion of that study I showed you, because prostate cancer tumor cells themselves rely on EZH2. So not only would we be inhibiting EZH2 in the prostate tumor cells, but also hopefully in the T cells to improve immune checkpoint therapy responses. But I think we have to get more creative too, right? How do we target these to specific cell subsets? So do we need to come up with targeting nanoparticle targeting strategies, for example, that can just get the inhibitors to a specific cell subset like the M2 cells or those kinds of things. So I don't know enough about that, but I know there are a lot of engineering groups thinking about how to have specific cell subset targeting of these agents, which I'm looking forward to.
Okay. Oh, another from Eri.
Mhm.
Sorry to ask too many questions. Don't worry. Can we increase genomic mutations for immunotherapy?
I would love to think that's possible with radiation therapy. That's something that, I think the radiation oncologists are working on, because they also see that as an opportunity. You create these mutations and you create changes within the tumor microenvironment that should allow for neoantigen formation. The question is, do we have enough time between when the radiation is given and when a new immune response can generate? That's one. And then two is the radiation also killing antigen presenting cells like dendritic cells? So that way these mutations are not being presented in any way to help generate an immune response. So I think these are pieces that still need to be addressed, but I'm optimistic.
I think it'd be interesting too, even with certain types of alkylating chemotherapies, right? And some of these patients who have extended long-term alkylating chemo develop these mismatch repair deficient tumor cells. But, in the brain tumor space, it seems like it hasn't really increased the immunogenicity. It's like sort of parts of the tumor that grow out that maybe have lots of antigens or at least mutations, but they're certainly not responsive to pure checkpoint blockade. So you kind of run the risk, right, of bringing up clones that are just small that drive, right?
It's so true. And I mean, in the Centro de Mari and the group that's working in this is trying to understand, whether or not they need to give low dose radiation and, because maybe high dose is creating a very different setting as opposed to low dose. So it's all these questions I think that still need to be looked at.
So there are two questions more. Eri Srivastava is asking, can you unmute me to ask? So I don't know how. There are also panelists, Sami, no. How about nutrition as 4 option? And Laura Martinez also said, what do you think is the role of CXCL13 in the tumor cell with ARID1 and in overall survival?
So ARID1A is in the tumor cell. That's a mutation in the tumor cell. The CXCL13 is in the microenvironment, not in the tumor cell itself. So we think what CXCL13 is doing is actually leading to infiltration of T and B cells. And actually CXCL13 is more important for B cell recruitment. And that's why we think tertiary lymphoid structures can form, like I showed tertiary. So it's really, we're still working out some of the mechanism, because when we did the experiments, we used a CXCL13 knockout mouse. So it's a total knockout. We need to go back now and do some experiments in specific cell subsets of, immune cell subsets, and see if we change things, step by step. But we really think it's playing a role in B cell infiltration and maybe the T and B cell collaboration. And for the nutrition part, absolutely, I think nutrition and the microbiome are two pieces that I didn't touch on at all, but obviously I think those are very important in looking at responses. And Jen Wargo's group here at MD Anderson has done a phenomenal job at highlighting the microbiome and high fiber diet, low fiber diet, these changes that can change the microbiome and then change immune responses. So I think they have a few clinical trials that they'll be reporting soon on some of that. Just not enough time to address all of it, but yes, to answer the question, nutrition is very important.
Yeah, can you hear me? I mean, Sister Watson.
Yes,
Yeah.
yes, go ahead.
Yeah. So, because the reason I'm asking about the genomic mutations is everybody is looking only at the epigenetic modifications like EZH2 that might be toxic, it's not been like that helpful. So I'm trying to think in terms of more of looking at the DNA itself, trying to look for some markers that bind to DNA polymerase, for example, and block it, not necessarily EZH2 and then going around that. Are there markers that could be targeted directly into the DNA more than the epigenetic markers itself? So when the DNA is opening up during the S phase, it opens up for the replication, markers that can be blocked so that now you induce blockages, which is again mutations. And that might be a better immune response tumors.
Right. So you're stopping it during the time of DNA replication. And
That's right. Yeah.
So
that's
yeah,
right.
I think people are looking at DNA damage repair pathways, right? So can you inhibit the DNA damage repair pathways? And so the DNA, whatever DNA damage is occurring within this unstable setting, right? During you're not able to repair them. And so there are DNA damage repair pathway inhibitors that are being tested in combination, right? What I will point out is that, believe it or not, in order for you to get T cells and B cells, right, is that you have a lot of DNA damage ongoing, right? Imagine every time the B cells and the T cells are recombining in a way to have specificity, right? The CDR3 regions are really changing a lot in order for you to have specificity of your immune cells. So you are doing some changes within these immune cells as well. And would you be inhibiting that really leads to maturation of a B cell response, for example? That you require a lot of VDJ combination, right? If you look at VDJ recombination, that's a lot that's ongoing for these cells to really have their exact specificity. So I don't know what that impact of that would be on the actual immune cell, as they go through their development process.
Thank you.
So there are one more question from Sami Yanikian. He's asking plasmapheresis benefits.
We use plasmapheresis for toxicities, right? So when we're dealing with immune-related toxicities, sometimes that don't respond well to steroids or other drugs, we have found that plasmapheresis can help because some of these toxicities seem to be antibody-driven. So we've used rituximab in some settings to treat these toxicities, as well as plasmapheresis to try and get rid of the B cell response. I'm not sure if that's the question they're asking.
They only said plasmapheresis benefits, and the second one, toxins that interfere with immunity.
I hope I'm answering it.
That's a tough one, but
Yeah.
I think that's true, right? You can plasmapherese out lots of antibodies that sometimes even ipilimumab, right, and nivolumab, right? If they're inducing all sorts of toxicity, you can try to plasmapherese them out.
Yeah, for the myositis cases, we've done a lot of plasmapheresis and treatment with rituximab to try and help that, because we have seen that it's antibody related.
Yeah. Well, I think we should let her go, Bagel.
Well, thank you guys so much.
Thank you so much.
Thank you, everybody. This
Thank
is
you.
a really nice, beautiful to have Pam share data with
Yes.
us, and thank you very much. All right,
Thank you.
we'll
Bye,
see you
everybody.
again
Take
soon,
care.
Pam.
Bye-bye.
Thank you,
Bye-bye.
everybody.
Bye.